aortic dissection, penetrating aortic ulcer, and a traumatic aortic rupture. Tear in the intimal layer of the aorta in 85% of cases. The intramural hematoma is maybe 5%, penetrating atherosclerotic ulcer around 5%. Mean age 63.5. Prevalence of pain of any kind up to 96%. A severe or worse pain 91%. Abrupt onset of pain 87%. Chest pain or a sharp pain is described in 76 and 64% respectively. In mediastinum, the classic chest X-ray finding is only seen in about 60% of cases. We talk about back pain, tearing, ripping pain, but these are occur in about 50% of cases. When a tearing, ripping back pain does occur, it can be quite specific, but the sensitivity is such that you cannot use that to exclude aortic dissection. Similarly, pulse deficit, aortic insufficiency, murmur, while they greatly increase your index of suspicion because of the specificity, they are not sensitive enough to be able to exclude, with the pulse deficit occurring in just 28% of cases, aortic insufficiency murmur in just 32% of cases. A tearing, ripping, or a sharp pain will help you to decide, yes, I'm going to investigate further, but again, not to rule out. Risk factors when we're screening for these patients. So we mentioned the Marfans, particularly important in young patients. Similarly, a bicuspid aortic valve, a family history of aortic dissection, recent aortic surgery, or an abdominal aneurysm, all are important risk factors to ask for, which would an abrupt onset, maximal at the time, almost like how we describe a subarachnoid hemorrhage, a severe worst pain in the back of the head. Similarly, a sudden severe pain, maximal to peak intensity being very quick, is important. Often anterior chest pain will be associated more with the type A dissection, upper back pain more common in a type B dissection. Syncope can be the presentation, focal neurology. The elderly perception can be reduced, so not every single case will have severe pain, which is important to be aware of. Now, chest tightness is more common with ACS. Pleuritic pain should make you consider an alternative diagnosis often, such as pneumothorax or pneumonia. Abdominal pain is in less than 10%. In terms of the examination, looking for faint or absent heart sounds, neck veins, presence of shock, a blood pressure difference of 20 millimeters of mercury in each arm, the pulse deficit, signs of aortic root dilatation are important to look for, so wide pulse pressure, a diastolic murmur over the aortic area, any neurological deficit, hypovolemia. A significant difference in the blood pressures of each arms occur in about 20% of patients. Hence, while it's again important to look for because it's specific and helps us much more likely to order a CT scan, again, we cannot use it to rule out the diagnosis. 40% of cases of aortic dissection are missed, comparing to just 2 to 5% of cases of MI. You can see we need to raise awareness of this condition and its presentation because it's often not thought of, doesn't have as well recognized tools as, for example, coronary syndromes or many other common fatal chest diagnoses. When missed, the mortality rate is 1 to 2% per hour. Chest X-ray changes will only occur in 2/3 of cases, and it will miss 1/3 of cases of dissection. So again, it cannot really be used to rule out the diagnosis, although it may be helpful to help justify, for example, a CT scan. Said for MI, we can use the heart score, ECG troponins, coronary calcium scores. We're very well recognized tools. Similarly for P, we have the PERC score, Wells score, D-dimer, the Years algorithm, good risk stratification tools, observations and chest X-ray, inflammatory markers, which help with most cases of thorax and with the inflammatory markers of pneumonia, respectively. For Haves, we have a good history in a chest X-ray, tamponade, a good history ultrasound. So all these fatal chest diagnoses, the rest of them have pretty good tools. Now, does such a tool exist for aortic dissection? It's not completely validated, but it is often used, and many people use the aortic section detection risk score in combination with the D-dimer to help rationalize the use of aortograms. We're not completely validated. It's worth discussing. So there's 3 features. What we've all discussed already is high-risk conditions, which we mentioned about the Marfan's history of aortic disease, aortic valve disease known, recent aortic manipulation or known thoracic aneurysm in the past. We have high-risk pain features, which are sudden, abrupt onset, severe or a ripping, tearing chest, back, or abdominal pain, and high-risk exam features, which we mentioned, which are the pulse deficit, blood pressure differential, focal neurological deficits with pain, an aortic insufficiency, murmur, or a hypotension or shock state on the observations. Each of these will give a point. Now, if ADD score is greater than 1, you proceed straight to a CT angiogram. 0 or 1, and then you do a D-dimer, and if the D-dimer is greater than 500, then you proceed to a CT angiogram. If the score is less than or equal to 1 and the D-dimer is less than 500, then it says you can, according to this score, which is not completely validated as we said, justify not proceeding to CT angiogram. So this is probably what the best thing we have right now. 1 out of 4 cases of dissection is under 53, and for those that have this under the age of 40, only a third have hypertension. Most of them are these Marfan's, Ehlers-Danlos, etc. 3 out of every 1,000 patients with chest, back, or abdominal pain may have a dissection. You have 1 aortic dissection for every 80 MIs. This aortic dissection detection score, refer to the advised trial to read more about this. There are some criticisms of this. Some would say that a patient with an ADDS-RS score of 0 and no high-risk features has an extremely low pretest probability, and hence maybe ordering a D-dimer for these patients may be unnecessary and lead to additional imaging. So that's one possible criticism some people have. Are more likely to pick up an aortic dissection with a CTPA. Most PEs will not be picked up with a dedicated dissection scan. History and your examination and your other features don't help you in that instance to really have specific features for, say, for example, dissection, and you're still not sure, could this be PE, could this be dissection, sharp pain in the anterior chest. In this situation, a CTPA will definitely help you pick up a PE, and it will give you a very good idea, quite likely to pick up a dissection. An ECG, STEMI or NSTEMI sort of patterns, if you've got a big clue as it could be a dissection, then you may want to withhold blood thinning treatments and get the urgent aortic imaging first. ECG features associated with aortic dissection include non-specific ST segment T wave changes in 40% of patients, acute ischemic changes in 15%. The pattern can occur as well in 3% of patients due to extension of the dissection process into the coronary ostium. 8% of patients with acute aortic dissection will have a normal ECG. Several X-ray changes, we said not always, which include a widened mediastinum, a globular heart, loss of contour of the aortic knuckle, tracheal deviation, a calcium sign, a left apical cap, left pleural effusion, to rule in but not necessarily rule out. Transthoracic echo is not good enough to rule out dissection. Transesophageal echo is an ideal test. Has a sensitivity of 90 to 98%, like we may with transthoracic echo. 50% of type B dissections will be missed by transthoracic echo. So it may have a role alongside CT scanning for a bit more information rapidly, but it definitely shouldn't be used to rule out the diagnosis. The aortic root dilated 4 centimeters, pericardial effusion. If aortic dissection is not the cause of patient symptoms, then a CT will help you pick up other diagnoses which may not be the case with, for example, transesophageal echo. A CT can help you pick up further esophagus, reg fractures, even pancreatitis. Sensitivity is not yet 100%. If there is a complete thrombosis of one lumen of the dissection, classification of both the true and false lumens, it can very, very rarely miss a dissection. And intramural hematoma could also sometimes be missed on a CT. While it's a very, very, very good test, if your whole history and examination is so suggestive of dissection, then it's something to bear in mind that the very rare dissection may be missed still by CT. So we have the Stanford classification system, type A, type B. Type A involving ascending aorta and descending aorta extending. Type B only the descending aorta. A is mainly management, whereas B can be managed medically as well, but may require endovascular stenting if the patient has persistent pain, rapidly expanding aortic diameter, or mild perfusion. Type B dissection should still be managed in an IHDU and refer to vascular intervention team if complications arise. Blood pressure lowering medications include betalol, esmolol, metoprolol. Advantage of esmolol is it's shorter acting. Betalol contraindicated in certain situations, such as a relative contraindication of severe COPD, for example. Metoprolol can also be used. Line drugs, if they're already on a beta blocker, could include GTN, sodium nitroprusside. Type B dissection from open surgery is not indicated, should be monitored for pain, expanding aortic diameter, development of a hematoma, and hence they should be monitored in HDU, ICU. A few take-home points: ADDS iris or D-dimer tool, but not absolutely validated. D-dimer has a high sensitivity but low specificity. Unfortunately, patients presenting with no high-risk features of aortic dissection will always be a challenge. Currently, we rely on a very, very good history, risk factors, physical exam findings, and the combination of tests to make a verifiable diagnosis by the Bolam standard, judged on what a reasonable practitioner would do, and just do a determined, thorough assessment. And please do cross-reference some of this with your own reading and research and looking at papers. This is what I've experienced and read. Thank you.